With this study is a phase 2 study. It's a single center trial conducted at the Translation Neurotherapeutics program at Georgetown University. It enrolled a little bit over, I think, 43 patients. Half of them were on a placebo, and the other half were on 200 milligram nilotinib. So this study is basically based on a very long, I would say, history of studying nilotinib. First, nilotinib was studied in a seminal study was published in 2016. We had a mix of patients who have advanced Parkinson's disease and lower body dementia. This was an open label study, so there was no placebo there. And what we found, there was a strong suggestion that there was an improvement there. At that time, we did not really understand what the improvement is, but patients all did better. Okay, specifically patients with lower body dementia. We moved on to a phase 2 trial in Parkinson's disease. These were moderately advanced Parkinson's patients. To dissect out the effect of the motor effect from the cognitive and behavioral effects, we basically studied patients who were almost cognitively intact with more advanced motor symptoms up to 1 year. We didn't see much change between placebo and low 150 milligram or high 300 milligram nilotinib for almost a year. We did an open label study. There was a strong hint that basically if you give the drug over 27 months, patients who have Parkinson's disease, who suffer from motor symptoms, they actually have a stable disease, which means they do not progress over 27 months. And this was important. All right. We also did another study, albeit like a much smaller study in Alzheimer's disease, where we enrolled about 40 patients as well. Half of them were on placebo. The other half were on 150 milligram nilotinib for 6 months, and we escalated the dose to 300 milligram for 6 more months. So over 1 year, of course, for Alzheimer's disease, there were mild to moderate Alzheimer's patients. We did not see any cognitive effect other than we had a hint in basically the trial-making test. Like patients had a slight improvement in their executive functioning. However, and most importantly, when we did PET amyloid imaging of the brain, we see that the amyloid burden in the brain was significantly reduced, particularly in the frontal cortex. And this was a study squarely aimed at biomarkers. We see that the level of amyloid as well as the level of tau were also reduced. And in both studies, in Parkinson's and in Alzheimer's disease, both studies, we tested the level of dopamine in the cerebrospinal fluid and also in the blood. And in both studies, we see strikingly a dose-dependent increase of dopamine levels in the brain. Okay, so here we have a scenario where you have a stabilization of the cognitive, stabilization of the motor decline in Parkinson's patients. The drug has no adverse effects. Actually, the placebo group had more adverse events than the nilotinib group in both studies. When we went to the Alzheimer's study, we see that if we go to a higher dose of the drug, 300 milligram dose, we see some mood swings. 70% of the patients actually had mood swings. So we lowered the dose to 200 milligrams, and here we said there is an unmet medical need here, particularly low body dementia. If you have most of the drugs that we use today in low body dementia, if you treat motor symptoms, you worsen cognitive and behavioral features, and if you treat cognitive symptoms, you worsen motor features. So this is a drug that could potentially, target this proteins, including amyloid and tau, and increase the level of dopamine in the brain that are known to be the culprits or maybe associated with Lewy body dementia. So we designed the current study. We treated patients with a lower dose of 200 milligrams because we didn't want to induce any any mood swings in these patients. And over 6 months, we observed that patients who were on 200 milligram nilotinib had an increase in dopamine, as we saw in the 2 previous studies, significantly reduced amount of amyloid, the concentration of amyloid in the cerebrospinal fluid, and significantly reduced of tau hyperphosphorylation. And when you look at other markers of inflammation, we also see a reduction in other markers of inflammation. So the biomarker studies here suggest that we could replicate what we actually saw in Parkinson's and Alzheimer's disease in clinical trials, and also replicate what we saw in almost a dozen in my lab, in other labs, in preclinical models when we use nilotinib. Now, strikingly, the biomarker effects with these drugs supported the clinical effect. So on ADAS-Cog14, which is the an endpoint that is accepted for measuring cognitive function in patients, we saw in as early as 3 months, we saw a significant improvement in ADAS-Cog of 2.8 points, and that improvement continued after 6 months, almost to 3.3 points. Now, as a result of that, when we looked at the number of falls, when we used motor measurements or motor outcomes, there was no change in motor functions. So we did not actually worsen motor functions. If you looked at the Unified Parkinson's Disease Rating Scale, you will see that only cognitive features were significantly improved, which corresponded to the improvement in ADAS-Cog. But when you looked at the number of falls in the placebo versus the nilotinib groups, there was 70% reduction in the number of falls. 70% reduction in the number of falls. So that suggests that as you basically improve cognition, you probably reduce the number of falls. And that goes back to our 2016 findings where we actually think everybody improved, but how did they improve? We didn't actually understand specifically how, because it was an open label study. So now we have a better understanding in a disease population that has dementia, that has motor features, and also have some behavioral features. Now, also, when we looked at cognitive fluctuations in these patients, we see that motor fluctuations, although it's very hard to measure in patients, over 6 months, the placebo group continued to fluctuate significantly. However, the patient group that was on the placebo, on nilotinib, that were stable throughout the study from visit to visit. So all of this, in total, it suggests that nilotinib is safe. 200 milligrams nilotinib improves cognition in patients, reduces the number of falls. It does not worsen motor effects, and it probably has an effect on motor fluctuation, which is pretty much a behavioral effect in these patients. So we are in this study addressing the unmet medical need and the chief medical complaint in Lewy body dementia patients. Our biomarker studies do support the clinical studies, and we think right now the logical thing is to move to a larger phase 3 multi-center study where we study cognitive decline in Lewy body disease, including Parkinson's disease dementia, as well as Lewy body dementia patients.